Hi, and welcome to the How to Survive Healthcare podcast. I'm your host, Kayla Thompson-Riviere, seasoned critical care RN turned independent patient advocate. Tune in every week so that you can learn the things about the U.S. healthcare system that no one ever tells you. That way that you can get the most from it and optimize your health outcomes. Now, of course, this podcast is strictly to inform and entertain and should never be taken as a substitute for medical advice. Let's dive right in. Hello, welcome back to another episode of How to Survive Healthcare. This week, I have another very special guest with me. I am honored today to have Marion Davis speaking with us. Marion, tell us what you're here about.
I'm here because a lot of people have a spinal leak and they don't know it, or if they do, they can't get to good care. What I'm working on is many different aspects to this problem that I have noticed with my several years of having had first a spontaneous spinal leak and then trying to get care and being given many spinal leaks along the way. We have a joke in the spinal leak community that you may not start with an iatrogenic, a medical injury, spinal leak, but you will definitely end up with an iatrogenic leak. Some people have their spinal leak started from medical injury, like an accidental puncture during a labor epidural. And then some people have their spinal leaks started with spontaneous leaks, often because of disc issues. But those patients, unfortunately, also tend to end up with medical injury leaks while they try to get care because of doctors not following best practices in research and not adjusting for different factors in giving care. A lot of them don't have enough training, unfortunately, due to lack of focus on this in medical education, despite the prevalence of this problem.
Wow, another episode here where more things to be scared of that you didn't know. It is one of the things that is my mission with this podcast is to kind of pull back the curtain and show that doctors are wonderful, incredible people, but that doesn't mean that they know everything. And that doesn't mean that we can blindly trust them. And, unfortunately, you have stumbled upon a segment of medicine that is probably more true there than in other areas.
Yeah, and you mentioned fear, which stands out to me as an emotion that I see a lot. I had started talking about my journey on TikTok, and I was an educator before, so I think that stood out to a lot of people and how well I was able to take things and explain it to them. And I was describing what I was learning in my own journey. I kept taking what they were teaching me, reaching out to a lot of doctors and learning more and more about this so I could be better at advocating for myself and recognizing problems with care plans they were coming up with. But as far as fear, while self-advocating on TikTok, I would have people reach out to me commonly and say, please get on the phone with me. Please tell me that I have cancer. Please tell me I have multiple sclerosis. Please tell me I have anything except a leak. I'm terrified. Now, when I describe this to anesthesiologists, because there are two main people providing care here, radiology and anesthesiology. Anesthesiology typically does not know that radiology is taking care of a lot of the chronic or the persistent leak cases. Anesthesiology typically sees people in the acute stage. But radiology has really asserted themselves as the thought leaders here. So they're like, spinal leaks are so easy to fix. Why would someone be terrified? Why would they rather have cancer? But the reality is a lot of people have spinal leaks that it's not, they have a spontaneous spinal leak, so there wasn't a clear, beginning point as much, just like with a labor epidural. I have read reports where the doctor noted everything, the radiologist noted everything that pointed to a spinal leak and wrote even in there that it was a young woman coming in with headaches, and then he just dismissed it all and said none of it was important. And it's called the Bern score in Switzerland, where the doctors came up with a quantitative way to read the brain MRI, and a lot of people are looking forward to AI helping read. brain MRIs. But the reality is that a lot of doctors are not using what is out there in research. And there was a great article I read by a man whose wife was diagnosed with cancer around the same time. It took him 2 years to get spinal lead care, and the second blood patch worked on him. And he talked about how there was a clear set care plan for her when she had cancer. And yet for him, he had to wander around to this doctor and that doctor to finally get diagnosed and have care. And honestly, his experience compared to others sounded very uneventful. 2 years and not any big hiccups, but just being set in circles. I mean, a lot of people, unfortunately, are being injured to the point where they're ending their lives while trying to get spinal lead care. And by injured, I mean, 13 lumbar punctures in 1 year, as the doctor keeps testing them over and over to see if they have low pressure when that's not even what should be assessed. It's low volume that current research has indicated is what should be assessed, and that should be assessed through looking at brain structures. So it's the lack of a clearly outlined care plan that is what's scaring a lot of people. And a lot of people in the spinal lead community say, I wish I had cancer. And what they really mean is, I wish I had support.
Right.
But then you look at news articles love to write stories sometimes on spinal lead cases because it's pretty much magical. There's so many stories that we've seen of people who are totally bedbound and they get a blood patch and then boom, they're good to go. They're out driving in 2 days. I know a couple people who had either surgical repairs for a surgical leak and were out, everything was fixed. It does take time for the healing process, but your brain gets popped up pretty immediately. There's a 2-part way that a blood patch works. So with the spinal leak, you have a hole in the dura, the lining around the spinal cord. It's like a hydraulic system. There's a lot of pressure going into keeping the spinal fluid up in your head. It gets cycled through the system, but you need enough spinal fluid up in your head. When there's a hole in the lining around your spinal cord, there's so much pressure because of gravity that it's coming out, and you'll often feel pain at the site. That's a well-known sign in literature, is pain at the level of the leak. And you can also feel like tugging, suctioning, all of these changes in epidural pressure. And when you have a hole in the dura and that spinal fluid cannot stay up in your head to lift up your brain, which reduces from the experience of your brain weighs 3 pounds without buoyancy and only a few ounces with buoyancy. It's very heavy, it hurts, and it descends on your skull bones, which is a large part of the pain, along with like pulling nerves and muscular pain from bracing against the weight. But when the doctors inject blood into the epidural area, the first part of the process is just the blood compresses around the spinal cord because it's filling up the epidural space. And it's like squeezing a toothpaste tube. Okay. And so it immediately pushes spinal fluid up to the head. And I've had that part happen. It feels great. Boom, everything's up. I have seizures as well that happen as a common symptom. I have secondary POTS. I have secondary MCAS. I remember when my brain shot up and was lifted up with buoyancy, and I can normally feel exactly where my brain is in my head. It feels like this heavy bowling ball rolling around that rests against the sharp edges inside your skull. And, you're like, oh, today is a little bit, to the right and front. I always describe it like buttons because there are different parts. People are in a personal hell with the spinal leak is what I call it. Because wherever their brain rests, and maybe it's affected by their gender, their particular skull shape, they will have more symptoms that fall along those lines, even though they can still have a very wide range of symptoms. My brother has a spinal leak. My uncle has a spinal leak. My cousin had a spinal leak. My grandfather had a spinal leak. And this is on both sides of the family. These are spontaneous. And then 2 sisters have iatrogenic, the medical injury. But my brother who has it, his forehead hurts. His brain rests against his forehead. And because his brain is descending there, he has schizophrenia symptoms, which is one thing that's covered in research, is that spinal leaks are a known cause of
Interesting.
schizophrenia.
And how many of those people with schizophrenia are getting evaluated for spinal leaks?
My brother was committed after one episode where he was struggling to sleep and was smoking pot, which can lower your brain pressure more. There are several documented cases in research for Parkinson's too. It's a known cause for Parkinson's. There are many things that a spinal leak can cause, to the point where I've seen the impact in my own family. And unfortunately, my cousin had schizophrenia and he ended his life earlier this year. I'm fairly certain he had a spinal leak based on our family history and his symptoms. And he had other common correlating things like gastroparesis. And in our family, we have EDS on both sides. And it is sad. And I'm sorry, I'm sorry for everyone going through this. I'm sorry for myself. I'm sorry for seeing them struggle. But at the same time, I do stop and wonder, like you were saying, how many people with schizophrenia have this? How many people with Parkinson's? If we streamlined care, we have so much research right now on spinal leaks that's just not being used by doctors because of lack of awareness. And just a big issue too is that the blood patch has a very low insurance reimbursement, which I think is why it's not emphasized in medical education. I think it's very hopeful with how fixable it is and with how well it works when done well. And I think it could be the big thing of the 21st century is better diagnosis of how many spinal leak cases are underlying. We do know that it's a common cause for POTS, and we see how much POTS diagnoses there are out there. A lot of them are women who had a lumbar puncture and were told, no, there's no way you have a spinal leak. Spinal leaks don't last. And you had a labor epidural and they're told, no, you can't have a headache past 7 to 10 days. One anesthesiologist told me that if patients persist with symptoms after the 7 to 10 day allotment, then that means they have psychosomatic symptoms. And I'm like, sir, I don't think, they woke up at, midnight the next day and after 10 days and it just magically was psychosomatic. Physiological one day, psychosomatic the next. No. But the research, the physician, the anesthesiologist I've seen who writes the 7 to 10 days a lot, and he also has a CME, a continuing medical education course on blood patches where he mentions it in there. I have read his research and he just throws it in anecdotally, which is why I encourage patients with my research background to actually go look at where these doctors are getting their information from.
Right.
Are they just, is Bob just randomly claiming this, or does he have research to back it up? Because there was a study in the UK, as I forget their name, they call themselves like the Accidental Dural Puncture Collective Group. I would have to double check that, but they conducted a long-term research study where they followed up with women who had been punctured during a labor epidural, and they found that I believe 60% of them still had a headache. A lot of them still had back pain at the site of the labor epidural at 1.5 years after the puncture.
Wow.
And a lot of long-term research shows this when they actually follow up with the women, is that no, they're not getting better unless they have.
They're not getting better. They're just getting ignored.
No, they don't magically heal at 7 to 10 days. Now, people can absolutely heal to a point where their bodies can compensate enough. That definitely, the body is amazing at compensating and at healing. And some people might not need a patch, even if they had a puncture. They might be able to heal to a point where, sure, they probably still have the small hole, but it's not enough to really bother them.
Sure. Now, you've told us a lot of sad things, but you're not just here to share the bad news. You're working on changing this for people, aren't you, Marion?
Yeah, well, I mean, there is a lot going on. And I think sometimes when I talk to people about this, because problems excite me, it's not always good to be experiencing the problems, but problems excite me because once you define a problem, then you can solve it. Yes, sometimes I start talking about problems with people and I think it overwhelms them because they're not used to me being like, oh, yes, defining the problem. Now we get to solve it. So a lot of doctors have said, oh, research on spinal leaks, it's new. The father of spinal anesthesia in 1890s realized when he started doing spinal anesthesia on patients, that a lot of them were complaining about a headache. So he and his assistant gave each other spinal leaks to see what it was about and journaled what it was like in the 1890s. And since then, there has been research on spinal leaks and just an incredible amount of research, to the point where in my own work, I raise awareness of this issue with anesthesiologists. And I tell them that, radiology has mainly taken over and the results are pretty disastrous. I think radiology does excellent work with helping better assess in non-interventional ways, but radiology has done a lot with helping come up with ways to better assess brain MRI, coming up with ways to use non-invasive imaging, if that could be applied consistently. But I don't think that interventional radiology should be giving blood patches from what I see. I think anesthesiology needs to be doing that more and focusing on how to give care in chronic spinal leak cases, in these cases where the women have been ignored for a year and a half or more, maybe 6 years, 10 years. 15 years is the longest I know of a woman who's been bedbound. And I do see more skills, a higher level of skills in anesthesiology for the actual intervention. I raise awareness with them on the need for them to address chronic spinal leaks. I started a database with an assistant and we contacted anesthesiologists, pain medicine anesthesiologists across the US, and we're presenting them with a case study on how they would go about it. And we got many different responses. Someone offered to inject PRP into my spinal fluid, which would cause a new leak, and put blood byproducts in my CSF. So some of the responses you get, it's like, no, thank you. One physician said you can't give blood patches in a chronic spinal leak case, which is a common thing I've seen anesthesiologists not know, that you could do that. I said, no, you are wrong. I said, we're keeping a database on competence. You are incompetent. You can come back to me when I'm seeing so many people dying from it.
Well, that's the thing. You do care.
I do care about their feelings some, because I want them to succeed too. I think this can be mutually beneficial, but I'm a little fed up. And I care about the patients too, even though sometimes I get a little fed up with them too, but with the ones who take it out on me. And emotions are running high in this area. And to his credit, because that anesthesiologist showed me what could happen. He was the department head for the pain management department at the regional hospital. I just randomly got an email from him a week later, and he said, well, I had all this experience at Vanderbilt before. I have to admit, I never really came across a spinal leak case, but after you call me incompetent, I have to admit that I was incompetent in this area. Wow. And he said, I went and did the research. I saw you could give blood patches in chronic spinal leak cases. I saw that spontaneous spinal leaks are actually not uncommon. And he offered a plan of care for how he would go about treating my case that I knew aligned with best practices. And he told me he created a CME and taught his whole department so they could better identify cases and treat patients. Radiology tends to be more aware of this, but anesthesiology, not so much, which, as I've always said, it's like everybody has one piece of the puzzle and they're not talking to each other.
Right. That applies to all of healthcare.
Yeah. And so I feel like, I'm the go-between. I'm like, actually, okay, the patients are saying this. Okay, anesthesiology, did you know radiology is doing this? And they're like, wait, what? And we're like, radiology, okay, anesthesiology is doing this.
Yeah. So what do you have to say to the person who had an epidural for their baby 6 months ago and has been having back pain and headaches? What would your suggestion be for their course of action? They went to their doctor and they said, oh, you had back pain, you had a pregnancy. What do you expect?
So I have found that seeing my own sister's experience with a labor epidural leak that thankfully was able to self-heal somewhat. First of all, prevention is important, preventing it from being worse. Learning what can make a spinal leak worse, like lifting heavy things, exertion, and make sure that you are testing what is being told to you about that. For example, my sister was told that she just had the baby blues and needed to go lift heavy weights.
Oh my
And
God.
that ripped her leak open more.
Right.
So I would do research first on what can make a spinal leak worse and just pay attention to your own body. Like being careful about lifting things. There's no bending, no lifting, no twisting normally. And then if someone is recommending that you lift stuff, maybe consider that they might not know what they're talking about and just double check everything you hear. Do not assume anyone will know what they're talking about with spinal leaks. Then I would start doing research, but be very cautious about misinformation. I would dig deeper than just what you see on Google because a lot of that is just regurgitated stuff from studies that were flawed. If you look in Google Scholar on things, you can find many studies that match with the experience. I think it's Niraj, NIRAJ 2021, that talks about it officially says that the International Headache Society's definition of post-dural puncture headache, PDPH, as self-limiting is likely incorrect, and that women will tend to have symptoms long-term, as they proved in their research study with many participants, that women will continue to have back pain at the site of the leak and head pain long-term unless it is fixed. And I would take research like that with you and self-advocate at appointments. If people try to tell you things like 7 to 10 days, you're crazy if you continue to have symptoms after that, say, no, the science supports that my experience is actually very common. They
Right.
often would try to tell you things like, oh, it's just you're the only one we have whose experiences. I can guarantee so
They just wrote them
prevalent.
all off.
It's so prevalent. Yes, they probably all have just been dismissed as well. But there is extensive research that supports this. Just dig deeper than Google. Go into Google Scholar or try to find research studies to support that, because there are many research studies to support what we, the patients, experience and what doctors say is abnormal, because the doctors won't check the research.
Sure.
And
Yeah.
they're very open with me about that.
Well, and it's interesting because, healthcare is just like many industries actually advancing at such an astronomical rate that it's great because we're learning so many things that, how many conditions can we treat now that 30 years ago would have been a death sentence? It's
Yeah.
phenomenal, but it's also becoming a point where it's almost difficult to keep up with. Kind of like, they say computers, like as soon as a computer comes off the line, it's already obsolete because the technology has improved. It's almost how it is with doctors coming out of med school. Like there's already new stuff from what they had learned that now needs to get caught up. I read somewhere that it takes on average, I think, 17 years for new research to become standard practice, which
Oh, yeah.
it's just too long. I mean, I don't know the answer to other than, like you said, educate yourself and advocate.
Well, yeah. And what I've tried to do is work on this from many different points. I have one client who provides AI solutions in healthcare, and I've seen that too with more places trying to put the guidelines for each, because I have found, and I've told patients this too, ask the anesthesiologist, are you following ASA guidelines? And normally they'll be shocked that you know what those are.
Right.
But the ASA guidelines support them providing care in many cases where they're not following the guidelines. And so if you bring that up, it kind of gives them a little zap, and they're like, oh, this patient might know some things.
Right.
And so I said, always ask them that. Are you following the ASA guidelines? And look up the ASA guidelines. But I do agree that it's hard to keep up with things. I was a PhD candidate before all this started and had to leave because of some issues in my department and my health. But I think that AI holds a lot of promise here, because I have seen some companies offering AI solutions that just spit out the guidelines, because a lot of doctors don't know their own society guidelines on all the different conditions, and they're not
Right.
looking it up. And then I say to the patients, you're part of this ecosystem. Push back. Even if you trust them, push back. My dad was a project manager in the Southeast and led a lot of teams during the rise of all the mobile networks. He developed a lot of them. He's just an inspiration for me in my career, but he would always say, trust but verify, trust but...
Constantly.
So, yeah, I tell the patients, even if you really like your doctor, don't give over all of your health decisions entirely to them.
Absolutely.
Trust but verify. And they should be receptive. I mean, a lot of them might not like that, but they should be receptive to it. And honestly, who cares? If they don't like it, oh well. But push back a little, ask some questions. Be like, okay, so you said this plan. Can you tell me your rationale behind it? I just want to understand this better. And I've found that is really helpful too.
That's a great approach.
You can tell a lot as far as someone's competence and how they approach problem solving if you ask them to tell you how they got from point A to point B. If they can't tell you, they have no idea, then that's probably a red flag. If they're like, well, I've had patients do this, and I've noticed if I adjusted to do this, and I've had some patients who are a little bit more petite, so I had to do this and adjust for this, then you've got a winner. That's someone who's adjusted in a lot of and obviously has a lot of clinical experience with specific to blood patching, which is a rarity. And then I've also worked with reaching out to a lot of nonprofits and community education, because I think this needs to be a community education part too. And I have worked with past clients before to secure partnerships where the nonprofit will take care of a grant and then partner with a smaller for-profit on community education materials. And I personally, in my own business, I just won a small business grant through Comcast to cover some of my community education approaches. And what I do is I then loop those opportunities back to the doctors.
Right.
And
congratulations on that.
Thank you. But I get the doctors involved, and even the doctors who want to practice spinal elite care in private practice, like anesthesiologists who I work with as well, I loop them into community education opportunities that are paid, because I say, one thing I've noticed with physicians is that a lot of them get stuck in the hero mindset sometimes of the ones who do care.
There are good doctors.
There are good doctors. There are ones who really care, but I found that they struggle with boundaries. And so they're like, oh, I want to help, but like, I don't want it to be about money, but I kind of need money. It's like, yes, you should be charging for your time. I want you to charge for your time, because you're going to burn out. And some of them will like, oh, I don't want to take money for this. And you're like, okay, well, I know you're not going to last for long, and they never do.
Right.
So I try to loop the paid opportunities back in, and I'm like, use this as a paid learning opportunity. I don't expect you to know everything. I do highly value your clinical experience if you've had that in blood patches, and I just want you to fine tune on that as an anesthesiologist who's used to doing that in an acute setting to prepare for the many, many people who passed that window a long time ago and are out there in the wild not knowing what on earth is going on. But I want you to be paid for that experience. And I want you to, be spending some non-clinical time on research. I guess because my background in academia, I see this as like time in the classroom and then time researching. So I work with anesthesiologists on how to have a cash-based business in spinal leak care, because some patients are paying $750 to have a patch with an anesthesiologist because it's so rare to have access to an anesthesiologist instead of a radiologist, while anesthesiologists in the hospital under contract and taking insurance are only getting paid like $75 a patch. And really, they tell me that because of the financial issue, they can't do too many patches, or that they are dependent, if patients are coming in through the ER, they're dependent on the ER doctor diagnosing, which is very, very iffy.
Right. Yeah, I my background is ER, and I often tell people, I'm like, we're really good at diagnosing and treating heart attacks and strokes and that sort of thing, but when it's something kind of rare and on the outskirts, the ER is not the place to be.
Yeah, well, I mean, some people have had obvious spinal leak. I mean, some people have come in with lumbar puncture leaks to the ER and gotten patched. And the thing is, unfortunately, that is the only way people can get patched, which is why I try to work with doctors to set up outpatient care in a more streamlined way, but have them take cash, because that's the only way that they can survive financially.
Right.
And in the long run, it's better for the patients, because patients are spending at least $20,000 a year typically in costs for not having access to good spinal leak care. And I feel like if we could just work with this whole ecosystem of raising awareness through the grant coverage, looping in doctors to get paid on those projects to work on their knowledge, setting up cash-based businesses so doctors could not deal with insurance undervaluing the blood patch, which I think is one of the most valuable tools out there. I mean, at least from my perspective. And considering how many people likely have a spinal leak as the root cause of schizophrenia, Parkinson's, POTS, chronic migraines, all of these conditions, it's worth much more than $75, and it's costing patients so much. I've estimated that in the US we have probably a $1 trillion market in spinal leak care, and yet it's unrecognized.
Wow. Well, I certainly, on behalf of all the patients, appreciate the work that you're putting in to take a personal, something that was a personal, awful experience and to turn around and do some good with it. Thank you. For anyone listening who either has or has not been diagnosed, but maybe thinks they have a spinal leak, where should they go for resources?
I had provided a Facebook group that I co-moderate with a friend. She has a cranial leak and a spinal leak in that group, because we were seeing a lot of issues with people accepting anything the expert said without really testing the veracity. We made a focus in that group on people only being able to people only sharing research sources and providing answers from research, and double checking that the research sources were actually solid study designs. And I'm not sure how you can share the link.
I'm going to put the link in the caption section of the podcast, but if you just want to share what the group is called.
Oh, I forget. we just did our CSF leak research discussions.
Okay, perfect. So, folks listening, you can either search for that on Facebook or look for the link in the caption here. Well, Marion, this has been so informative, and I appreciate your time so much. Before we head out, is there anything else you want to say to listeners?
No, I would just say, I guess the one thing that I always emphasize is it's hard when you're suffering to wait, but don't jump in, because a lot of these providers unfortunately don't really know what they're doing, and they may have the best of intentions but still recommend harmful things. I have seen so many people get harmed so much more by seeking care that I would really encourage you to do a lot of time and reviewing all of the risks. There is a high risk of puncture for an epidural blood patch, which we are working on as well as another part of my project. There is often no need for a lumbar puncture in the context of being diagnosed for a spinal leak, and yet they will recommend that before non-invasive. That is very likely, and it's up to a 60% chance of giving you a new spinal leak. And then, of course, the research. So the research shows that you will likely continue to have a spinal leak, even though this will often be downplayed. It is very true. And I have seen people with spontaneous leaks still be functional and then lose their entire careers and lives because of a lumbar puncture in this context when it was unnecessary and not supported in research. Spend your time, even though you're suffering now. I mean, I hate to sound really negative, but it could be a lot worse.
Proceed with caution.
Yeah, that's a more concise way to say it.
Got it.
Proceed with caution. Take your time. Really, really review all of the risks.
Yes, and head over to Marion's group where they only share the highest quality information.
Yeah, and we
Good
just
resources.
challenge each other and go over study designs.
Yeah, that's awesome.
Share research across disciplines, because it gets so siloed into radiology and just organized by who's the expert.
Right. Well, look at you breaking down the barriers.
Yeah.
Thank you. Thank you for what you're doing for the community. And thank you for your time, Marion. It's been wonderful having you here to chat today. And to the listeners out there, thanks for being with us. And I will see you next week. Bye-bye.